Welcome to section 3 of cardiac embryology. In this section, we'll be discussing right to left shunts. Let's get started. The following disease processes are considered right to left shunts. A mnemonic to remember the diseases is 5 T's. So tetralogy of Fallot, truncus arteriosus, transposition of the great vessels, tricuspid atresia, and total anomalous pulmonary venous return. Right to left shunts occur when blood passes from the right side of the heart to the left side of the heart without being oxygenated. This leads to ventilation-perfusion ratio mismatch, or VQ mismatch, as well as hypoxemia due to the smaller amount of oxygen entering the blood. This type of shunt presents with early cyanosis because deoxygenated blood is entering the systemic circulation, so the tissues are not adequately oxygenated. These conditions are immediately life-threatening and should urgently be treated with either surgery or maintenance of a patent ductus arteriosus, or PDA. All right, let's begin by discussing tetralogy of Fallot. This is the most common cause of cyanosis in newborns. The exact cause is unknown, but it's generally recognized that it's due to an anterior and superior deviation of the infundibular septum in the developing fetus. The infundibular septum just refers to a part of the ventricular septum. Tetralogy of Fallot is made up of 4 components, hence the tetra prefix in the name. These 4 components can be remembered by the mnemonic PROVE, which stands for pulmonary infundibular stenosis, right ventricular hypertrophy, overriding aorta, and ventricular septal defects. You should also know that tetralogy of Fallot is associated with fetal alcohol syndrome, as well as 22q11 syndromes. Here's an image illustrating the 4 components of tetralogy of Fallot. Here is the overriding aorta, pulmonary stenosis, a ventricular septal defect, and right ventricular hypertrophy. The overriding aorta just means that the aorta is positioned above the ventricular septal defect rather than directly over the left ventricle, so it's shifted a bit this way. I find it easier to remember that tetralogy of Fallot causes pulmonary stenosis, an overriding aorta, and a VSD. The right ventricular hypertrophy is much more logical and can be easily remembered. This is because pulmonary stenosis causes more blood to build up on the right side of the heart, which means the right ventricle has to pump harder. Over time, the right ventricle must adapt, which results in hypertrophy. Also, you may be wondering why this is a right to left shunt if there is a VSD. After all, because the VSD is typically very large, the pressure in the left and right ventricles are approximately equal. So let's say that the pressure, or P1, which represents the pressure in the right ventricle, is approximately equal to P2, which is the pressure in the left ventricle. Blood flow follows the path of least resistance. Because there is pulmonary stenosis, the high resistance in this region is greater than the resistance in the aorta. So it's typically easier for blood to travel from the ventricles into the aorta. So there's high resistance right here and lower resistance in the aorta, which means blood likes to go from the right side of the heart and then into the aorta like this, even though the pressures in the ventricles are approximately equal. As you can see, this results in a right to left shunt, which is a big problem because the deoxygenated blood from the right side of the heart goes directly into the systemic circulation, resulting in hypoxia and cyanosis. So, as I just mentioned, the pulmonary stenosis causes increased resistance near the pulmonary artery, which results in blood being shunted from the right ventricle to the systemic circulation. A common association with tetralogy of Fallot are TET spells. These are hypercyanotic episodes that occur in patients with tetralogy of Fallot, and they commonly occur when the infant is agitated, upset, or in pain. The mechanism is unclear, but there are several proposed mechanisms of how this can happen, including peripheral vasodilation, hyperventilation, and increased contractility of the right ventricle. However, the important thing to remember is that all of the proposed mechanisms result in worsening of the shunt. Finally, you should know that older children experiencing a TET spell will often squat to recover, so squatting improves symptoms. This is because squatting increases the systemic vascular resistance, or SVR, which in turn increases the pressure on the left side of the heart and helps reverse the shunt. Let's draw this out so you can see what I'm talking about. So here we have an image again of tetralogy of Fallot, and we can see the 4 chambers of the heart, and a shunt that goes from right to left due to pulmonary stenosis and increased resistance near the pulmonary artery. A TET spell can occur if the outflow tract to the pulmonary artery is worsened, which then exacerbates the shunt. So if there's increased resistance here, then this right to left shunt is worsened. This in turn causes more deoxygenated blood to enter the systemic circulation and cyanosis ensues, like we talked about earlier. Now, squatting can help alleviate the cyanosis because it increases the resistance through the systemic vasculature by compressing the vessels in the abdomen and the lower extremities. As we know from our cardiology equations lecture, a smaller vessel radius leads to higher resistance. So if a patient squats and the vasculature is compressed, then the systemic vascular resistance, or SVR, increases. So let's show an increased SVR in the aorta. And again, this happens when the patient squats. This increase in resistance makes it harder for blood to leave the heart and enter circulation, which leads to decreased cardiac output. This translates into increased blood volume on the left side of the heart, which then increases the pressure on the left side of the heart. Now that the left side of the heart has a higher pressure, the shunt is reversed. As you can see, squatting essentially relieves the hypoxia experienced by a patient. The last thing you need to know about tetralogy of Fallot is that it's associated with a boot-shaped heart that can be seen with a chest x-ray. Notice from the image that the cardiac silhouette is shaped kind of like a boot. This occurs because of right ventricular hypertrophy. As the right ventricle enlarges, we can see an enlargement right here, which makes the heart have a boot-like appearance when viewed with an x-ray. All right, now let's discuss truncus arteriosus. To understand this better, let's quickly review the normal development of the heart. Remember that during development, the great arteries arise from a single trunk, which can be seen in the left image over here. So notice that at this point in development, there is a single vessel leaving the heart. A wall forms in this trunk to divide the heart into the pulmonary artery and the ascending aorta, and this occurs by about the 5th week of pregnancy. Truncus arteriosus occurs when this division fails to happen and the aorticopulmonary septum fails to form. So we can see the aorticopulmonary septum forming right here. And if this fails to happen, then we don't get an ascending aorta and a pulmonary trunk. Instead, we get one single vessel leaving the heart. And this is known as truncus arteriosus. So truncus arteriosus is due to failure of the aorticopulmonary septum to form. This commonly occurs with a ventricular septal defect, which allows blood to travel directly from the right ventricle to the aorta, hence the right to left shunt. Finally, truncus arteriosus is associated with 22q11 syndromes. Here is an image of what's going on with truncus arteriosus. As you can see, there is no septum in this great vessel right here. So the aorta and pulmonary artery are continuous with one another. This results in deoxygenated blood from the right ventricle entering the aorta like this, which then travels to the systemic vasculature. Finally, notice that because the main pulmonary artery directly branches off of the aorta, that some of the blood will end up going to the lungs. All right, now let's discuss transposition of the great vessels. This occurs when there is failure of the aorticopulmonary septum to spiral. This results in the aorta arising from the right ventricle and the pulmonary artery arising from the left ventricle. This condition is incompatible with life unless there is some type of communication between the two areas of the heart, such as a patent ductus arteriosus, an atrial septal defect, or a ventricular septal defect. Finally, it's more common among infants of diabetic mothers. Here's a picture of transposition of the great vessels. As you can see, the aorta leaves the right ventricle and the pulmonary artery leaves the left ventricle. You can see that the aorticopulmonary septum has failed to spiral, resulting in the aorta on the right side and the pulmonary arteries on the left side. As I mentioned on the last slide, there must be a shunt like an atrial septal defect in order for the offspring to be viable, and we can see an ASD right here. This allows some of the oxygenated blood on the left side of the heart to move to the right side of the heart. From here, the mixed blood can travel from the right ventricle into the transposed aorta and ultimately to the rest of the body. In this way, the tissues at least receive some oxygenated blood, even though it's not ideal. Okay, now let's discuss tricuspid atresia. This condition occurs because of congenital agenesis or absence of the tricuspid valve. This results in no direct communication between the right atrium and ventricle. Tricuspid atresia also results in a hypoplastic right ventricle and is incompatible with life unless a VSD and an ASD are present. Let's pull up an image of this so you can see why. As you can see in this illustration, there is no connection between the right atrium and the right ventricle. An ASD is present, which allows the obstructed blood to move from the right atrium to the left atrium, hence the right to left shunt. There is also a ventricular septal defect, which you can see right here, and this allows blood to move from the left ventricle into the pulmonary artery, like this. As you can see, both an ASD and a VSD must be present in order for this condition to be compatible with life. If the ASD were absent, blood could not move from the right atrium to the rest of the body. And likewise, if a VSD were absent, blood could not move back to the pulmonary artery and become oxygenated. Also notice from the image that this condition is associated with a small or hypoplastic chamber of the right ventricle. All right, moving on to total anomalous pulmonary venous return. This is a congenital heart disease in which all 4 pulmonary veins fail to make a normal connection to the left atrium. This results in blood draining into the systemic venous circulation. This condition arises from failure of the left atrium to link with the pulmonary venous plexus. There are several anatomical variations of total anomalous pulmonary venous return, depending on the severity of the abnormality. It's associated with atrial septal defects, and a PDA may also be present. Here is a picture of total anomalous pulmonary venous return. You can see that the connection between the left atrium and the pulmonary veins and all of the blood from the lungs goes into the systemic venous circulation. In this image, we can see blood going from the pulmonary veins to the superior vena cava and then back into the right atrium. This is a problem because oxygenated blood in the pulmonary veins goes back to the right atrium, where it mixes with deoxygenated blood. The mixture of blood then travels through an ASD, which you can see right here, which allows the blood to get to the left side of the heart. From here, the blood travels to the aorta and throughout the body. Okay, the final shunt we'll discuss is Ebstein anomaly. This is characterized by abnormalities of the tricuspid valve and right ventricle. The presentation is highly variable and can range from critical condition of a newborn to an asymptomatic adult. The tricuspid valve is displaced towards the apex, and the right ventricle becomes atrialized, and this is because of the downward displacement of the tricuspid valve. For this reason, the right ventricle performance is almost always abnormal. Ebstein anomaly is associated with an atrial septal defect, which is responsible for the right to left shunt. It's also associated with tricuspid regurgitation, accessory conduction pathways, and right-sided heart failure. Additionally, studies have shown that lithium exposure during pregnancy can lead to Ebstein anomaly in the fetus. Here's a picture of Ebstein's anomaly. As you can see, the tricuspid valve is displaced downward right here, and the right atrium is enlarged, which you can see right here. We can see that the location of the tricuspid valve and small cavity of the right ventricle results in tricuspid regurgitation. We can also see that an ASD is present, which causes blood to move from the right side of the heart to the left. This is because the pressure on the right side of the heart rises as the right ventricle fails to adequately pump blood into the pulmonary artery. The volume on the right side of the heart increases, the pressure rises, and blood naturally moves from the right atrium to the left atrium. I find it pretty easy to remember that this disorder causes accessory electrical pathways because I just remember how the right atrium is enlarged. Recall that the sinoatrial node is near the right atrium, so as the atrium enlarges, it can distort this node along with the electrical pathways emanating from the SA node, which can then cause electrical disturbances throughout the heart. All right, now that we've covered the disorders, let's review with a question. A newborn male is found to have hypoxemia and cyanosis. A chest X-ray reveals a boot-shaped heart. The physician informs the parents that their child has a right-to-left cardiac shunt that will need to be surgically repaired. What are the 4 abnormal anatomical features associated with this patient's heart condition? Okay, hypoxemia, cyanosis, and a boot-shaped heart are all highly suggestive of tetralogy of Fallot. With this in mind, we're asked about the 4 abnormal anatomical features of this patient's heart. Recall that this can be remembered with a mnemonic PROVE. P for pulmonary stenosis, R for right ventricular hypertrophy, O for overriding aorta, and V for ventricular septal defect. If we look at this image, we can see the 4 abnormalities again. So pulmonary stenosis, right ventricular hypertrophy, overriding aorta, and ventricular septal defect. And with that, we've covered everything you need to know about right to left shunts.